when we did our vaccinational trial against the CALR mutations, we thought that it would be a really good vaccine because the neoantigens formed are quite immunogenic. But what we didn't appreciate at that time was that the cells, not the tumor cells, because what is a tumor cell in MPN, but the cells that are recognized by the immune system, they are all over in the entire organism, meaning that they float in the blood. I mean, macrophages, the Kupffer cells in the liver, they are of myeloid origin. Do we know if they have the mutation? They should be potentially eliminated by CALR mutant-specific T cells too. So I think the main problem here is for vaccines to have effect is the tumor burden. For sure, CALR mutations, they are immunogenic, but we need to vaccinate patients when they have a really, really low tumor burden. And we actually did some quite hypothetical calculations on this some years ago, published in Frontiers in Immunology. But we found that we need to go extremely low in the mutant allelic burden to have a match between the number of target cells and the number of the effector cells that should kill the target cells. So to put it into the context of current and future cancer immune therapeutic modalities, I think what we can do now, what would be extremely interesting, it would be to perform therapeutic cancer vaccines in patients that had an allo transplant. Because what you do when you get an allo transplant is that first you have a very low tumor burden, and secondly, we put a reset on the immune system. Because we know that patients that have an MPN, they have a poorly working immune system. They have low priming potential from the dendritic cells. Hydroxyurea, how does that impact the efficiency or the efficacy of the effector immune cells? Whereas when you give in a new immune system, the immune system hasn't been subjected to these cytotoxic substances. So I think that both the low tumor burden and also the chemo-naive immune system after an allotransplantation provides an excellent time point of doing the vaccines. Secondly, I think that the vaccines could also be used when we use the monoclonal antibodies. I haven't seen the publications yet, but I saw a poster here at ESH where they show a drastic decrease in the VAF of patients, but still the VAF is too high for the vaccines to have an effect. I think we need to go below 1% in VAF before the vaccines can have any effect. Which could mean that maybe CAR T cells, after CAR T cells, vaccines could be efficient. Another thing that could then be done is to increase the fraction of, or the number of tumor antigen-specific T cells when you do the vaccines by using a different adjuvant. And in this regard, I think the Tuneci and Sachin groups from Mainz using the BioNTech mRNA technology, they have done a really, really good job because they have published several times. There was this paper in Nature some years ago in a collaboration with Memorial Sloan Kettering Cancer Center in patients with pancreatic cancer. And here, using their special mRNA setup, which I unfortunately cannot really understand the technology, but what they showed was that for some patients, the number of T cells in the specific to the tumor antigens in the peripheral blood was extremely high. So actually, for some of those patients, 1%, or I think it was maybe even 10% of the entire T cell repertoire in these patients was specific to the tumor antigens. And that was by using this specific mRNA technology, which increases the number of T cells specific to the tumor antigens, which gives enormous immune responses. And that technology, I think, is really, really intriguing to use. And there are some other trials also, what is called I think it was called the Amplify trials in pancreatic cancer, where they use this technology of molecular hitchhiking, and they thereby prime many antigen-presenting cells, not only in the regional lymph node where you vaccinate, but they actually they prime most of the dendritic cells, or they activate most of the dendritic cells in the organism, and hence they get a much stronger priming of antigen-specific T cells. So that's another technology that can be used. So we need to go down in tumor burden, and we need to go up in the number of specific T cells. That is a thing to use or to consider for future vaccination trials.